Let's move on now to secondary amenorrhea. Here's our case. A 32-year-old states her last menstrual period was 1 year ago. Menarche was at age 12. She was initially irregular, but since age 14 or 15, menses have been every 28 to 29 days. Well, that sounds about right. She has never been pregnant, has not been sexually active, has not used contraception. Her physical and pelvic exam is normal. How do we evaluate secondary amenorrhea? The most common cause of secondary amenorrhea is pregnancy. Don't forget that. So easy to rule out, beta-HCG. If she's not pregnant, we must think of anovulation. What hormone is missing here? Progesterone. If she is not pregnant and not anovulatory, then we need to think of another hormone which is missing, and that would be estrogen. If she's not pregnant, does not have a problem with ovulation, estrogen is okay, then we're basically stuck with an outflow tract lesion in the reproductive tract. So, pregnancy, anovulation, low estrogen, obstruction. We'll come back to this in just a bit. Okay, this figure shows the different manifestations of anovulation. Now, we talked about anovulation previously as a cause of abnormal bleeding. Here, we're talking about anovulation as a cause of amenorrhea. And this can sound a little bit confusing. How can it cause both? Well, as this diagram shows, initially, when you have the estrogen stimulation, the endometrium gets a little thicker and thicker and thicker and thicker and thicker and thicker and thicker, but not enough yet to where it starts shedding off because of its instability. But at some point in time, it gets thick enough that it will start shedding off irregularly, and that's where we start to get spotting, maybe heavy bleeding. So it can show up clinically as either amenorrhea in the initial stages or as menorrhagia in the later stages. You got that? Both of these can be caused by anovulation. Anovulation is characterized by a thin and watery cervical mucus, very stretchy. This is a German word, Spinbarkeit, which talks about the stretchability of the cervical mucus. When you have ovulation, the progesterone effect comes on and the cervical mucus becomes thick and sticky. Okay, secondary amenorrhea. The diagnostic criteria are no menses for 3 months if previously regular menses, or no menses for 6 months if previously irregular menses. We can also look at this in terms of hypogonadotropic, hypergonadotropic, and eugonadotropic. If it is hypogonadotropic, if the FSH levels are low, you know it must be hypothalamic pituitary dysfunction. You can take that to the bank. It is hypothalamic pituitary dysfunction. If the gonadotropins are elevated, hypergonadotropic, it is always because of ovarian follicular failure. And you can take that to the bank. It is always going to be ovarian follicular failure. So, the last is eugonadotropic, and that is where you have normal levels of gonadotropins, and that could be pregnancy and ovulation, uterine problems, outflow tract, and we'll talk about these later. Here we have two individuals who look similar, but one, it's a voluntary problem, and the other is involuntary, anorexia. This is a big problem in our society, particularly among young women. The woman who may be quite normal in appearance looks in a mirror, and what does she see? She thinks that she's fat. And one of the problems that we're looking at is what kind of image does the media portray as to what a woman should look like? It was really brought to the forefront when a Brazilian model died. Her body mass index was 13.5. 15 is usually used as a BMI for starvation. She was 5'8" and weighed 88 pounds. This is a major concern. New York is considering banning ultra-thin fashion models. Now, why do I talk about anorexia nervosa? Because this is associated with secondary amenorrhea. What do you think are the gonadotropins of this young woman? Low. I have never seen a woman with anorexia who is pregnant. With anorexia, she becomes infertile. Okay, as we look at secondary amenorrhea, and if we have ruled out pregnancy, the next thing we want to do is a progesterone challenge test. We can give intramuscular progesterone in oil, 100 milligrams, or 7 days of oral medroxyprogesterone acetate. If there is a bleed which occurs within 3 to 5 days of stopping the progesterone, we call that a positive progesterone challenge test. The diagnosis is going to be anovulation. We're going to find out if there is a correctable cause of anovulation, a hypothyroidism, hyperprolactinemia, so we'll get a TSH and prolactin. If those are normal, our basic approach will be to cycle her with medroxyprogesterone acetate, 7 days, every month or two, and the main reason for that is to prevent endometrial hyperplasia. If she wants to conceive and she's anovulatory, we would use clomiphene citrate. If after the IM progesterone or the 7 days of oral medroxyprogesterone acetate, there is no bleed, we know that it must be either low estrogen or an outflow tract obstruction. Our next step in management will be to give estrogen plus progestin challenge test. This is not an endpoint in itself, so we need to move on to the estrogen progesterone challenge test. We give estrogen progesterone, either oral estrogen for 21 days and then 7 days of medroxyprogesterone acetate, or you could just use combination oral contraceptive pills. When you stop this, there should be a bleed within 3 to 5 days. If there is a bleed, we call this a positive estrogen progesterone challenge test. The diagnosis is going to be low estrogen. The reason that the woman with a positive progesterone challenge test bled was because she had endometrium that was primed with estrogen, but it just needed progesterone. If you have a negative progesterone challenge, then you want to provide the endometrium with estrogen and then progesterone. Basically, you take away any hormonal excuse for not bleeding. If she bleeds after estrogen plus progestin, the diagnosis is low estrogen, then you want to find out why is the estrogen low. We're going to do FSH, and the FSH will tell us what the reason is. If the FSH is elevated, remember we said that is going to be always from ovarian follicular failure. If the FSH is low, it has to be hypothalamic pituitary axis failure. And if you have hypothalamic pituitary axis failure, you need to do some sort of imaging study of the CNS. This woman is basically postmenopausal. She's got menopause prematurely. She will need to have estrogen because of the effect on her bone density, and because she has a uterus, she will need progestin as well. If after estrogen plus progestin there is no bleed, we call that a negative estrogen progesterone challenge test. This must be an anatomic problem, outflow tract obstruction, and that's it. How do we find out where the obstruction is? You know it's not going to be in the vaginal agenesis. You know it's not an imperforate hymen. You know it's not because there is a transverse vaginal septum. It's going to have to be at the level of the cervix or higher because she's had previous successful menstrual periods. So we do an hysterosalpingogram, an HSG. An example of what could cause this is Asherman syndrome. Asherman syndrome is treated with intrauterine adhesion lysis with a hysteroscope and then high-dose estrogen to try to stimulate any endometrium which may still be present. A positive progesterone challenge test always is due to anovulation. A positive estrogen progesterone challenge test is always due to low estrogen. And you find out what the cause of the low estrogen is by doing an FSH. FSH is high, it's going to be ovarian follicular failure. If the FSH is low, it's hypothalamic pituitary problems. If the estrogen progesterone challenge test is negative, there's only one possibility as to what's going on, and that is an anatomic outflow tract obstruction. And this you assess using hysterosalpingogram. This is a hysterosalpingogram. Here you can see the instrument that is placed into the cervix. This is the cervical canal. This is the triangular-shaped uterine cavity. And you can see there is a proximal tube, distal tube, but the main thing I want you to notice here is there's a filling defect in the uterus. There's something which is keeping the dye from getting to this area. This is a partial endometrial adhesion. Look at the next picture here. You can see the dye is placed into the cervical canal. This is endocervical canal right here. But where is the uterine cavity? Where are the oviducts? You don't see that at all. This is complete endometrial obliteration, endometrial adhesions consistent with Asherman syndrome. This can be treated by hysteroscopic lysis of adhesions. This is an instrument that you use. You have a port here which you can put in instruments from the side. This is placed into the endometrial cavity. The adhesions are then lysed, and then a triangular-shaped balloon stent is placed into the endometrial cavity. And hopefully this will maintain the walls from adhering again, and we then stimulate with high-dose estrogen. This is a story of sisters, one who at age 14 underwent premature menopause. Her follicles disappeared. Her sister donated her ovary to the woman who had the menopause, and she successfully gave birth. Rather unusual, secondary amenorrhea. Okay, anatomic, hormonal cause of secondary amenorrhea, anatomic, pregnancy, and outflow tract obstruction. Hormonal is either a lack of progesterone, which is anovulation, or lack of estrogen, which there's a variety of different causes. Pregnancy is the most common cause of secondary amenorrhea. Anovulation is because there is no corpus luteum and progesterone is lacking, so you don't have the progesterone withdrawal. Low estrogen occurs when there are no ovarian follicles. Estrogen is lacking. And an obstruction of the reproductive tract is diagnosed with hysterosalpingogram. So, criteria for secondary amenorrhea: regular menses for 3 months if previously regular menses, no menses for 6 months if previously irregular menses. Beta HCG will assess if there is a pregnancy. If that's the cause, that you treat whatever the findings are, whether it's a normal pregnancy or abnormal. If she is not pregnant, then we need to think about anovulation, progesterone challenge test, we talked about that. If there is bleeding within 3 to 5 days, we call that a positive progesterone challenge test. It is always due to anovulation. We find out if there is a correctable cause of anovulation, get a TSH and prolactin. If she's hypothyroid, then we can replace that. One of the causes of infertility is anovulation due to hypothyroidism. She will need to have progesterone cycling to prevent endometrial hyperplasia. If progesterone challenge test is negative, then we give estrogen plus progestin. If your 80-year-old grandmother who doesn't have periods anymore, but who has a normal reproductive tract, was given 21 days of estrogen plus progestin and then stopped, what should happen? She should have a withdrawal bleed. And the reason she didn't before is because she had low estrogen. We can find out the cause of the low estrogen by doing an FSH. If it's elevated, it's going to be ovarian follicular failure, premature menopause. If it's low, it's hypothalamic pituitary. But she will need both estrogen and progestin. If estrogen progesterone challenge test is negative, then we do a hysterosalpingogram to find out where the obstruction is, and this is always a surgical management. And that is the end of secondary amenorrhea.